Okay, well, thanks for the invitation. I think I have a speaker here, and if not, the back of the room will tell me. So I'm an intellectual disability physician, and that's why I always start with this slide to do a little bit of promotion for international groups, because it's a specialization which only exists in Holland. Leonore Kuipers is also an intellectual disability physician, and it was actually designed for us to take over from pediatricians when children reach the age of 18 to continue to give care to these vulnerable patients. So we see patients with tuberous sclerosis complex, but also with lots of other genetic syndromes with neurodevelopmental disabilities. Today I will talk a little bit about the transitional age phase, which is a little bit mean because I can talk about it for hours and now I only have 20 minutes, but I will try. I will present some cases, present a little study we did in young adults, and then end with some recommendations. First, I'll present to you Anouk. She is in her late 20s. She came to me with fatigue and sleeping problems. And when I talked to her, and I've been talking to her for these last years, she tells me she had a very good start as a child, developed infantile spasms, but responded very well to treatments. Her epilepsy disappeared, and she followed a very normal neurocognitive trajectory, normal schooling. Afterwards, she continued with a university degree, even finished her law studies, but she stayed at home during those studies because it was very difficult for her to plan and organize her life. After her studies, however, she had a very difficult time. She couldn't find a job which really connected with her educational level, so that was very disappointing to her. She switched from job to job. She couldn't move out of the house because she still had difficulties organizing her own life. And these troubles are getting better now. So now she's living independently, still has not very many friends, but she has a job that really suits her, and she's pretty happy now. This shows us that transition can take a long time, and that expectation management is very important. This is Jaap. I also have seen him a lot these last years. He's 19 years old. His parents came to me because he was very anxious. Actually, his parents have been very well prepared for transition. They organized a house for him with other parents, with very nice friends that they knew from his daytime occupation as a child. But just when he was about to transition out of the home, he became so anxious that they weren't able to do it. He stayed at home, had many tics, many anxieties, couldn't go to his daytime occupation, was crying a lot, and yeah, mood swings for the whole day. So that was pretty sad. So they were so well prepared, and still was difficult for them. So what do we know about his age phase? It's been talked about before. I think it's very important to emphasize the physical problems as well, because they're very interconnected with mental health problems. And we know in this age phase the renal problems start to occur. The SEGA risk goes down, but also the epilepsy can be very variable, because many children are less compliant, their biorhythm changes, also acceptance of TSC is a big thing, so the epilepsy can be can get more severe. Also, the cardiac rhabdomyomes are not a problem, but the facial features also can get worse, and this can cause a lot of anxiety. So the physical symptoms, they do get worse in a time when patients rather not talk about them. But also other physical problems do occur. I think it's important to show this slide because in patients with ID, these are often overlooked, even by TSC specialists. And it's very important not to focus only on TSC manifestations, but also on other more general health issues in people with ID, but also in the general adolescent population. Because of this change in lifestyle, you can get lots of other health risks as well. But we're here for TAND, so what do we know about growing up with TAND? Well, when you look at the literature, it's very, very little, and it's pretty sad, I think, that we know so little, because it's a very complex time, and I think maybe even the worst time on a mental health domain, but I don't want to scare parents in the room. But we do see, of course, the autism persists and becomes very variable, and we know with life events, autistic features also can get worse just because there's reactive stress, more maladaptive behavior, and you get this in a transitional age phase more. So it's very good to be prepared for this. ADHD, we know there's a lot of underdiagnosis, but when it's diagnosed, it's often in the teens and often because of behavioral problems which are difficult to manage. So you see that a lot of children start with psychotropic stimulants and psychotropic drugs in teenage years and even in late teenage years. And I saw for Smith-Magenis, there was really around 17, 18 years old that there was a huge rise in psychotropic drugs. And I think it might be the same for TSC as well, but there's no data on that either. Then the adjustment disorders, I really want to emphasize. People don't talk to them a lot, but we all know when the bus driver changes, when a caregiver changes, but also very little things like an incident at the swimming pool or an incident with friends. That can cause a lot of stress and disproportionate stress. And we know in TSC, there's a very nice publication by Susanna Boronat that very little stressors that we would not experience as a stressor in TSC, it can have huge effects. So it's very important always to ask with changes in behavior, was there really not something that happened? And don't just go for the major life events, but also very small life events. So that's on a DSM level, but then we have the more psychological and behavioral level. Of course, we know the TSC phenotype. I think for this age phase is there are two ways to look at it. For the higher functioning people, it's very difficult because they have many failures in their teenage life. This is a time when they sort of grow into deficit, we call it. So they lag behind more and more compared to their neurotypical peers. So they see their limitations more and more. And in their teenage years, that's very difficult to experience. So people have a low self-esteem, they develop depressive symptoms, they develop social phobias. It's difficult for them to communicate, to ask for help. So people can get very isolated and develop many internalizing symptoms. But also the externalizing symptoms you see more, maybe more in the lower cognitive levels when people ask too much, because these people also lag behind more and overestimate it, you get more of the externalizing symptoms. So we see that a lot as well. But this is what we know a little bit. When I was setting up the 18+ clinic in Rotterdam, I really wanted to know what do our people need and what are their concerns. So so I would be able to provide the proper care providers for them, because I know an intellectual disability physician people are not really eager to see because my title is just very wrong, and I don't want to say to people that they're intellectually disabled the first time they walk into my room, but I do want to provide the proper care for them, and usually that's not a doctor but also other specializations. So we did some qualitative research, which is very tough research to do, as some of you might know, but we developed some interviews and focus groups. So we had a lot of young adults, but also parents of young adults in focus groups. We had also did one-on-one interviews, and people talked about all domains in their life. And how do you organize that stuff? Because when people talk, they talk a lot, and there are many domains to discuss. And that's why I love the ICF, and that's one of the messages I want to give to all care providers, because TSC is messy business, as I say it, and it's really nice to structure your conversations, but also your care around the ICF to really understand what you're doing. So like Jaap, we know his body functions and structure, like the mental health problems and the TSC manifestations, those are all in the physical and mental health domain. But the ICF really helps us to also think about activities and think about participation, and also think about environmental factors like parental stress, like the organization of support, like availability of finances, such things. So if we use this as a sort of a theoretical how do you say it, overview, also in our heads, even in our letters to other doctors, you can give advices on all of these domains. It's really nice to keep it structured. So also in our interviews, we use this, all these discussions were transcribed word for word. Well, you can't imagine how much time this costs, and you have to do this with 2 people. Then from all these discussions, you get certain codes and meanings out of every sentence. And then you get hundreds and hundreds of codes. From all of these codes, these students had to distill specific themes, overarching themes of things which are most important to this patient group. Afterwards, you discuss these themes in expert groups to make sure we didn't miss anything or maybe overemphasize things. So for these adults with TSC, in this qualitative research, these were their major themes and concerns. And as you can see, and we're talking about 10 today, that's not all physical manifestations, and it's actually a lot more than that. So we see these people worry all the time. They worry about future, they worry about their relationships, about their epilepsy, about going to school. And it's the same for parents. They worry all the time as well. So I guess it's not very bad news, but now we know about it, we may be better prepared in the future. What's important is that they didn't talk a lot, the parents even, didn't talk a lot about the behavioral problems. So it seems that at some level this was clear to them and it didn't change so much and their expectations weren't so different. But their cognitive limitations, these were discussed a lot. So even though we do our neuropsychological exams when children grow up, there were still some difficulties that they didn't understand. So I think that's very important. And a long time ago, I did a study on intelligence and adaptive behavior in children. And this may explain a little bit because you saw that in children, if you look at a time lapse about 3 or 4 years in between, there was a change in adaptive functioning per year that was significant. So on the Vineland that some people know here, there was a significant change or a decline in the adaptive functioning for the whole group per year. And for the intelligence quotient, there was a change of 2 IQ points per year, which was not significant. On the other hand, if you extrapolate, if you do NPO at 11 years, and if you look at this change per year, around the transitional age phase, it may mean that they really have declined in functioning. So not just growing into your deficit, but a real decline. And that's why I think it's important what Petra said, really do this neuropsychological examination before school ends to really be prepared for the future and not to overestimate our people too much. So they had a lot of questions about relationships and family planning. And I think it's also an important lesson for the pediatricians in the room to really start talking about this at a very young age and not to talk about things in limitations, but really how do you think about this and what do you feel about this? It was very difficult in these groups to talk about sex, maybe because it was in groups, but I know from my own consultation room and because I really try to pay a lot of attention to this, this is a big issue that people are very shy, it's very difficult to engage in just verbal relationships, and physical relationships are very much to ask for many people, and they really may need some help with this. And also relationships with themselves, sexual relationships, they are very hesitant and they really don't know what to do. So I think it's very important also to address this issue. But also questions about heritability. These people, they really had no idea. They had heritability percentages. Some said 30%, the other one said 80%. And that's very good, I think, to inform people at a very young age about this, so they know what they're talking about. And let's look at these contextual factors. We've talked about them before, but I think these are very important because we can do something about this. Many things about TSC were still powerless, but the infrastructure, information, transition, we can control as caregivers. So I think it's very important if we improve this part, we may also improve a lot of mental health issues as well. So, we just, in this qualitative interview, we talk the talk. We ask, what are your worries? We have the 10 checklist of Petra's, which really helps us address the mental health problems. And people, of course, say, I know now, I have the 10 for the mental health. I have my physical examination for the physical health. How do I address these contextual things? Well, then we are developing the CHAT TSC. So CHAT, of course, means talk. I'm really happy about the acronym, although I know the child psychologists in the room, they know it from something else. But I think because it's developed for adults, I hope it's okay. But this addresses TEND. So the TEND is also incorporated into the CHAT, but also the physical manifestations, also the contextual factors are addressed. So it's really a sort of quality of life questionnaire, which will hopefully address all needs in our consultation room, but maybe also be used as a patient outcome in the future. If we talk the talk, we have to walk the walk. And I have colleagues who say, okay, so now I can talk about the tent, but I have no idea what to do with it. So it's really difficult for me to address. And then people look at me expectantly. So I told you all my troubles. What do I do with this? I think it's very locally very different. So I suggest you talk to GPs a lot about these things and see what in the patient's environment is possible in support. And also in our paper we address and we really give some concrete advices. There are guidelines, of course, coming out. Of course, new guidelines are coming out, and Anne told me to do some more promotion because in Holland we have a guideline which is really nice, multidisciplinary guideline of problem behavior coming out next year, which is also going to be published in English. So hopefully that may help because it's really for adults and not children. So now we know how to talk the talk and to walk the walk, and now we can help Jaap. So of course we help him himself. I did give a little bit of citalopram. Of course we don't want to over-medicate, but he was worrying and ruminating and persisting in his worries all the time. And it really did help him. I took after he was stabilized, we discontinued, but his anxieties returned immediately, so he's still now on the citalopram. He stabilized, he's went to another home to live in. He has a really nice job now and is very happy. And this picture his mother's actually sent to me this weekend because he was with his new home at the beach with his new friends. And he was just a very happy camper. And that's not only because we did some intervention with medication, but also because we did all these things. We helped the parents, we educated the parents were helped themselves, they went to talk with a psychologist as well, and we did this in an interdisciplinary way. So I think it's a really nice example of how to work. And for Anouk, also this happened over these years, so she got a lot of help. People are always asking me to prove some cost effectiveness to my job, and I say I cannot prove cost effectiveness because everybody, because I'm very expensive, and everybody who walks into my consultation room gets so much support that I can never prove that it's cost effective. But I think the long-term effectiveness is very important, and I think actually if the pediatricians in adult care are communicating more and more, then the pediatricians and they do this already, of course. So it will only get better. So this is it. We have a big team at ENCORE. I'm very happy to work with because I learn a lot from the pediatrics for the adult care as well. And we did this together with the Utrecht group. And I'm happy to be in the TSC 10 panel with Anna and Petrus and developing also the chat with them. So that's really nice. Thanks for your attention.
Thank you, Agnies. We're approaching the end of the afternoon, but we can handle one or two small questions, if there are any questions. Don't hesitate. Yes, please.
Do you think the problems in mating and building sexual relationships, are they just merely due to the psychological and neuropsychiatric factors, or are there other factors like knowledge of carrying dominant disease, the skin manifestations, etc.?
Yeah, a really nice question. Of course, we don't know a lot. Sexuality is also always approached from a biopsycho-social perspective. The biological factors, there are many too. There are some sexual expression abnormalities like Kluver-Bucy syndrome with epilepsy and TSC. We know, of course, side effects of psychotropic drugs. Anti-epileptic drugs also can have effect on sexual development. Mental health problems have huge effects on sexuality, like you say. So there are many, like embarrassment and shyness, but I have no idea about really which is most important. And I think TSC is so variable, and the sexuality in TSC might be even more variable than that. So, but it definitely needs more attention. Yeah.
I got one more question here.
It's not a question, just to say something. I have TSC myself, and I have a 6-year-old boy without TSC. So even, okay, every TSC patient is different, but some of us can cope with quite a normal life. Just to say.
Yeah, thank you so much for saying that. And of course, also as Dr. we're always talking about limitations and problems.
I have some limitation and problems.
Yeah. Okay. Good. Yeah. Yeah. We all have. Right.
Okay.
Yeah. No.
There is good stuff too. I mean.
Yeah. I'm so happy you say that, and I think tomorrow we will hear more about competencies, strengths and weaknesses, and I think it's a much nicer way to look at things instead of like the problems like we say. So I'm happy you say that. Thank you. Yeah. Yeah.
Thank you very much.
Yeah.
Okay, the next speaker will be Iris Overwater.